So,
good afternoon, everyone. My name is Valentina Tageo. I'm the founder and director of Ysengol. We are a Spanish SME, proud partner of the Alameda project, and we are in charge within the project of dissemination, communication, and stakeholder engagement activities. But most importantly, today I'm pleased to moderate this session, which will kickstart a webinar series of our AI for Brain community of interest together with our partner project, Lethe. So before starting, let me just take a few seconds for housekeeping information. As you will see, all attendees have their microphone mute by default, but of course we will be gladly taking your questions during the open debate slot in our agenda. So please just feel free to ask for questions either by raising your hand or by writing in the chat. Also, for your information, this webinar is being recorded and the recording will be posted in both Alameda and Lethe communication channels as part of our dissemination and engagement materials. So, why the AI for Brain community of interest and why this webinar today? I will just briefly introduce the rationale behind. As most of you know, Alameda and Lethe are two European research projects that have been funded under the same H2020 call, which were seeking for personalized early risk detection, prevention, and intervention solution based on AI and big data. And both projects, of course, have a common ground as they are dealing with the complex challenge of neurodegenerative diseases. When we met, of course, we immediately thought that it would make much sense to join forces, try to steer a community that hopefully could progressively expand also to other AI practitioners, researchers, patient organizations, policymakers, and clinicians, of course, which are working in this realm with the intention, first of all, to share the results and lessons learned from our studies, but also to promote more in general a collective reflection of what's next in terms of personalized brain health solutions in the EU. And why this webinar today? Of course, this webinar is kickstarting this collaboration. So you will hear from representatives from the two projects about the latest and promising AI-based solutions for improving the understanding of the course of neurodegenerative diseases, and specifically in this case, Alzheimer's, Parkinson's, and multiple sclerosis. And this is crucially important because neurodegenerative disorders are very complex illnesses that provoke progressive loss of functionalities and can, of course, imply resulting in profound impairments for patients. And although we know, and we increasingly know, the early onset signs of these diseases, their clinical course is still largely unknown, and which pose an incredible burden on quality of life and well-being of patients, which of course is summing up to the fact that resources are often lacking at the healthcare organizations to conduct a continuous monitoring, and the clinicians face very big challenges to make accurate diagnosis, but also to design personalized treatment plans. So without taking more time, I will introduce briefly our agenda today. And as you will see, we count on an invited guest today from the European Commission, Kyriakos Atzara, Policy Officer from DG Connect, who kindly accepted our invitation to help us to set the ground of this discussion. So we will immediately hear from Kyriakos about what are the most important updates for what concern brain health research and policies in the EU. And then we will leave the floor first to Lethe and Alameda representative to present the study and the challenges they are facing in the running of our pilots and what's next in the development of our projects. So, Kyriakos, I will leave the floor to you and stop sharing my screen.
Thank you, Valentina. May I just check you can see me well and hear me well as well? Okay.
Yes, we do.
So many thanks once more and good afternoon to all attendees and many thanks for the opportunity to address you today on a very important topic for us. I am Kyriakos Hatzaras. I'm a program officer for EU policies here at DG Connect in the unit of e-health, well-being and aging, working very closely with our head of unit Marco Marcella and heads of sector Saila Rine and Michiel Swears on policy strategy and implementation aspects. So for us, brain research, brain care and mental care are very important areas as we look at the European and global trends in epidemiology and equally opportunities now available in terms of new technology for neuroscientists and brain healthcare and mental care practitioners. Epidemiological trends have been concerning, if not worrying, for a number of years now. I remember the numbers when I was working on mental care policy as a young researcher some 15 years ago now, and the latest estimates of the European Academy of Neurology make for a sobering read. In 2017, 307 million patient cases in the then EU 28, including the UK, in a population of 515 million, with 20 million disability-adjusted life years lost. Not to mention the impact on family members and carers. So more than half of the European population, approximately 60%, is impacted by neurological disease, and at the same time, the number of available professionals, neurologists and others, available to provide care for citizens across Europe is disproportionately low. And yet, at the same time, we have opportunities to tackle this disease burden that now emerge in the realm of technology, in simulations of neurological mechanisms. For example, complex large computational models are applied to the human brain. These have become increasingly reliable, in part due to advances in brain imaging. A neurological model can now be developed using an MRI scan of a patient's brain, and on this basis, new possibilities arise for treating conditions such as epilepsy, for example, via brain stimulation, for which current mainstream treatments and approaches are considered to be either ineffective or unsatisfactory or both. And it is exactly on this nexus of advances in neuroscience and technology, prevention and treatment, that the European Commission has been focusing attention and very sizable investment for several years now. I will refer to three examples of the many existing, starting with the Human Brain Project and its 123 partners launched in 2013 for a duration of 10 years as a European future and emerging technologies flagship. Co-funded by the European Commission and including partner contributions, it has now reached a total level of funding of 607 million euro, engaging more than 500 researchers at all levels in 16 countries and achieving some 2,000 publications. So all very significant numbers. In the Human Brain Project, highly advanced methods from computing, neuroinformatics, and artificial intelligence are used to conduct leading-edge brain research globally. Knowledge generated is then translated into novel applications in healthcare and technology use, and the social and ethical implications arising from brain research and its applications are also addressed. A second large-scale example is eBrains, which is a dedicated digital research infrastructure created by the Human Brain Project that now makes available an extensive range of data and tools for brain research. It draws on cutting-edge neuroscience, big data, computing, robotics, and other technologies to help translate the latest scientific discoveries into innovation in medicine and industry for patient and societal benefit. And of course, eBrains is built on the Phoenix technical infrastructure, and this allows its users to exploit the powerful high-performance computing and analytics services of some of Europe's leading supercomputing centers. And if we then look as a third example at the volume of projects and funding awarded by the European Research Council, the premier European funding organization focused on excellent frontier research, they speak for themselves. The ERC project database shows that up to 190 projects on neurodegenerative diseases with a total of 324 million euro were funded until the end of 2022. And when we look at all aspects of brain research, including cognitive science and other domains, we see up to 1,144 projects funded across 280 institutions in 26 countries with a budget exceeding 2 billion euro. Now, of course, these numbers are very significant, and if not anything else, they signal a large constellation of organizations involved, a robust focus in Europe, and opportunities now and in future, particularly for our younger colleagues, researchers and others with a passion for brain research. And all this activity is now observed at a very important moment. And this is because, on the one hand, the political negotiations of the proposed European Health Data Space regulation are advancing well, and digital health authorities and other stakeholders across the member states are engaging in certain key projects to define and co-create the ways in which new e-health services across our countries become a reality for citizens and patients, users and non-users of these services. Also, EU investment in new technology, new infrastructure, for example, Simple, the smart middleware that is aimed to connect all European data spaces, of which healthcare is expected to be one, that is progressing as well. And of course, we see also progress with the European regulatory framework, with the Data Act adopted in 2022, the proposed Data Governance Act, and the proposed AI Act. So in healthcare and in digital health more specifically, our vision in the framework of our coordinating role and collaboration with the member states is to start seeing some of the more advanced services gradually deployed on appropriate infrastructure with the requisite groups of stakeholders to the benefit of citizens and patients. For example, some of the interaction and sensor-based technology and predictive methods and tools developed in the two projects, Alameda and Lethe, informing both pharmacological and non-pharmacological treatment options, including those in remote trials, very useful for that side of healthcare in itself, and the focus on health literacy and empowerment, extremely important for the adoption of any new solution in healthcare. Many thanks for your attention to these introductory points. Looking forward to the discussion, and once again, well done to both projects. Thank you.
Thank you so much, Kyriakos. It was very inspiring, and I would be happy if you could stay with us also for the open debate afterwards. I'm sure there will be interesting questions there. So let's go ahead with our agenda. As we said, we have structured it in two parts to listen from our key speakers today. So first will be the turn of Lethe with the project coordinators, then Anke from the Joanneum Research Institute, who will present how Lethe is trying to steer the most advantage of AI-based predictive modeling for the understanding of dementia progression. Then the floor is yours.
Thanks, Valentina. You can see my screen already?
Yes, we do.
Okay. Yeah, thanks for the invite for this inspiring webinar with the inspiring keynote already. and thanks for the chance to present our project here, the Lethe project. I'm the coordinator of this project. The project started in January 22 and runs at least till the end of 2024. I will give some insights. I will focus a bit more on the AI part because I think this is of the interest of the audience here. And yeah, with this I would start my presentation. So what is Lethe about? The idea of Lethe came from this one. I mean, it's one example. This publication you can see here on the right in Lancet, published in Lancet, which showed more or less that for chronic diseases there is a quite percentage of potentially modifiable risk factors. We have seen in the news recently that there have been also pharmacological results now in dementia, which are very promising. Nevertheless, for a long time, there were no real results. So studies focused more on these modifiable risk factors. You can see on the right here. And especially here to mention the FINGER study, which was a European study performed in the Nordic countries, showed the first time that lifestyle interventions could have a good benefit on dementia-related outcome parameters. Meanwhile, of course, these results have been also established by other publications, also a very recent publication from China. So the idea here, one of the basic idea in Lethe was or is to take this finger intervention protocol over to a digital intervention to open this innovation or this coaching intervention, let's say, in different lifestyle categories, open up for broader population and automate things with digital devices. Connected with the digital devices, you can see in point 2, of course, we have also the idea to collect more data, to be concrete digital biomarkers beyond the general medical data you usually collect in clinical studies with ICT components. We have here passive and active monitoring. What is meant with that? Of course, you have some lifestyle parameters which you can very good passively collect with wearables, Fitbit, Apple, and so on. You know the devices like physical activity and so on. But some parameters like smoking are hard to detect by ICT. And here we push questionnaires or provide the possibility to let participants enter data in an app we will provide. And the first point actually is the AI part. Of course, part of the project was as well, first of all, to analyze retrospective data we got from the beginning of the start. I will go a bit in detail on that. And as well, try, based on the medical data, but as well the digital data, to project the development of the participants, meaning the disease progression. So which data we talk about? Basically, we have in the project 3 categories. We have, you can see here also the number of data points or at least subjects. We have data from the finger data, which are intervention data, long-term intervention data on lifestyle with lifestyle parameters. Then we have from all the 4 clinical centers in the project, Karolinska, THL, Medical University, and Perugia University. Of course, the memory clinic data, the observational data, where we try basically with a model to project, like I said, the progression, meaning in future there might be the possibilities if patients enter the clinic and the data are entered in the EHR or in the system, we provide a risk factor of this person in general, and also how this person will possibly perform in different tests in the next 2 years, let's say. The third category is also very interesting. In Austria, we had the chance to get over 100,000 social insurance data, meaning medication data. Is a different data category compared to the others, but here we try to make analysis on this data to find out interactions between different medications. Because like you may know from literature, there are some medications which are not dementia related, which have a positive outcome to some dementia related parameters. One medication which is very well in press at the moment is metformin, for example, which has apparently a good benefit for dementia. And these effects we try to find out in these social insurance data with AI. But let's focus on the first part, the intervention data we got. Basically here we chose as the target parameter the NTP score, which is a neurological test battery, which has also been used in finger to say if a person get better or worse related cognitive functionalities or cognitive functions. You see, for example, on the right side, some graphs of individual patients, how they progress over 24 months in NTP test battery. So we have the data from the baseline visit, 12 months and 24 months. And the approach we followed here is that we trained a model and we used here the NTP as an outcome feature. And to be more concrete, the delta NTP of 2 visits, which means basically if the delta is very large, so to say, in a negative value, then the person very much decreased over the time. And if it's small, it stayed on the same level. The model incorporates several features from these data we have. You can see here a subset on the left side. This is based on 300 features, just a selection. We play around here with this model. It's still all under investigation. But you can see what is important, that you have, of course, demographic data, but also cardiological related data, blood biomarkers, you have sleep biomarkers, you have physical activity biomarkers. So all from different lifestyle categories. And we trained the model here on this data with, for now, successful accuracy of area under curve of 0.81. We know that we need to get a bit higher, but of course you understand that this challenge is also very high. What we get then is a histogram, a distribution of the delta NTP, and from one visit to the other visit. And like said, we here, for experimental reason, chose a cutoff point of 5% of the quantile. We also play a bit around with this parameter, where we say all patients which are under this cutoff threshold, so to say, have a high risk, and all the persons which are over are low risk categories. And now the idea is that we have this model, we can basically, with the patients which enter now our study, with January this year, we have the first patients included in the study, can from the beginning define or evaluate if they are a high risk or low risk person. Furthermore, we used here to get some explanation on the local, I mean the individual patient level, but also the cohort level. We use these Shapley values, which are a possibility in machine learning to show effects of the model, like I said, on global explainability, but as well as local explainability. And then you get such graphs, for example, where you see 2 things, basically, that you have, if you have a high value, this means that this value is tending towards a higher risk or leading the person to a higher risk. And if you have a low value, to a lower risk. And if you have a red color, then it means for high values, and blue color low values. This means, for example, age, second parameter you see here, it's clear that higher values, higher age, meaning red, is on the right side, so it leads to a higher risk for dementia, which is something which is of course very valid in literature. But you see as well that there are other scores, like the BL score, which is a nutrition score, for example, and also other scores, which also we get knowledge about how these scores are influencing the model, or how these features influencing the model on a higher risk or a lower risk classification. This is still very experimental, so please don't take these features yet in the ranking as relevant, because of course there are other effects we need to sort out, like for example medications. There can be a positive and negative effect, but this is the direction what we are going at the moment. And as well, you can of course for each individual patient do this analysis, and you can, for example, with the same coding like you have seen before, find out that, for example, blood pressure, lower blood pressure reduces the risk, like you can see here. And of course, you see also the amount of the value, giving an indication how strong this feature were influencing the classification of this person. So in future, we hope to have a dashboard, so to say, where you can see which factors are influencing the risk of the patient, and that then by intervention we can influence or bring the patient to a better state over time. You have the same example for an individual for the low risk classification here. And when we have then the transition from baseline, months 12, months 24, we can as well see, for example, if interventions had an impact on the change of the risk, and so on. So this is basically what we are trying to do now with the retrospective data and fade into our study, which we started, like I said, in January. And let me shortly say some words on this study. Basically, we can call it a hybrid study. We include 160 patients in 4 countries, like I said. So 80 patients or persons in the intervention group and 80 in the control group. The study protocol is a hybrid protocol, let's say. We have all lifestyle intervention categories addressed with digital tools, with an app and a wearable. But we have also as well in-person, face-to-face meetings on the different lifestyle categories, like sessions for exercises and so on. Because of course, we plan, like you see here, not completely updated a study of 24 months, which is quite 2 years, which is quite a long period. And to manage to keep the participant adherent to the protocol, we said that we cannot leave them completely digital. With the digital devices, we also want to have in-person interactions in between. So this is a kind of a hybrid approach, I would say. The main part of the study, of the intervention study, to collect the digital biomarkers is an app we developed with different functionalities in all these categories. Basically, you have a planning, or you can enter values, like I said before, like blood pressure, cigarettes smoked, how much you were drinking alcohol. You get pushed questionnaires where they answer data which are also used in clinical practice, for example, in the onboarding a bit more, but then also on bi-weekly, monthly level, how about the diet and so on, and other parameters, how they slept as well. And then they have, of course, cognitive training integrated by the partner Combinostics, also in the app. Meditation, what we address additional to FINGER, because stress and meditation has been shown also very related to dementia. We have physical activity videos additional to the sessions, and as well as the possibility to enter some nutrition data. What is a bit maybe innovative or a nice idea, I think, is these so-called tiny habits. I think my colleague Jeroen will talk a bit about it. Basically, here's the idea to change the behavior on a healthy long term. So behavior change mechanisms we try to implement here, and this tiny habits method, which has not been invented by Lethe, but by another author, has a bit the idea to connect a habit you want to learn to another habit you have. So for example, make push-ups before you brush teeth or something like this. And we provide tiny habits for all the lifestyle categories, and we try to push the participants following some of the tiny habits, not all, of course. And then we try to collect as well in digital terms how they manage to follow these own goals they set themselves as part of the intervention. And then, of course, you have also a calendar with your protocol intervention dates integrated, as well as a score of your progression. Like said, the intervention group has basically a variable where we try to measure passively a lot of data, and the app. We also provide a tablet for the cognitive training and the exercises, the videos they want to view. The setup for the control group is very similar. They have also a tracker because, of course, also from the control group, we want to collect this passive data, but they don't see the interventional content, meaning cognitive training, videos, and so on in the app. So the app they have as well, but in a much simpler form. And then, of course, also no tablet, but the phone comes with the app. Basically, this is displayed on this slide here. As a sub-study this summer, we plan as well a side study in Lethe where we play around with a robot as well as smart classes where you can use audio interaction to interact with the Lethe app, meaning getting the messages as audio, but also replying with speech interaction with the app. And we will try to find out here if such more innovative devices are usable for the target group and make the interaction with such a digital code more easily. To give you an impression of the digital data points we are collecting in the different phases, a lot of points are mentioned already, but there's a publication already out where there's a kind of nice summary in the different lifestyle categories, which parameters we get from medical side as well as from digital usage of the devices. So please feel free to read yourself further into the project. And with that, I think I stressed my time already quite a lot, and I would give over to my colleague Jeroen. And thanks for being here. Thank you.
Thank you, Stan. I will try to share my screen so I can use the... So if I'm correct, you're able to see my screen?
Yeah, not in presentation mode, but...
Okay, so I have to switch this. There it is.
Yeah.
Okay, thanks for the opportunity to be here and tell a bit about behavior change. Small disclaimer, my talk is not going to be about artificial intelligence or risk prediction, but about intelligent ways to promote brain health via lifestyle-related behavior change. My name is Jeroen, and I work as a postdoctoral researcher and lecturer at Maastricht University at the Health Promotion Department. And to give you a small introduction into health promotion often has to do with behavior change, either with increasing behavior that is beneficial to health or with decreasing behavior that is harmful to health. And
I'm sorry to interrupt, but I think you are back to no presentation mode.
Oh, now you can see my presentation.
Apologies for interrupting.
No, it doesn't matter.
No, it's still not in presentation mode.
It switches. No, it keeps switching. Okay, that's a bit weird. I will disconnect my second screen. Let's see if that solves the issue. Okay, I'm very sorry for the inconvenience here, but I'm still not in the presentation mode, huh, Stan?
Yeah.
Let me see.
Maybe start it again.
Yeah. This should do the trick.
Yeah.
Now, yes.
Technology, very useful when it works with you, huh? When we talk about this health promotion, it very often has to do with behavior beneficial or harmful to health. And that's a very broad concept because health behavior includes a broad variety of activities. Physical activity to prevent you from becoming ill, also talk about your complaints if you experience them, or making decisions about care if you need it. And all of these behaviors are very complex because they can be rational or irrational, reasoned or impulsive, conscious or habitual, or a combination of all of these things. And to navigate our way through that complexity of health behavior, we use theory because that provides you with a very useful framework to understand behavior. And theory often uses determinants of behavior to do so. And basically, these determinants of behavior are key factors that determine why people do or not do a certain behavior. And knowing about these specific determinants can help you to select behavior change methods. Because if you change one of these determinants, you are more likely to successfully change the health behavior that you would like to change. And knowing these determinants give you very useful insights to coordinate some of your intervention activities to optimize the support that you provide to individuals going through a certain behavior change process. And this is exactly what Maastricht University tries to bring in the Lethe project. And to give you a bit of an idea, I will use two of the studies that we do to explore these determinants of behavior that are relevant for the promotion of brain health and the prevention of cognitive decline. So we started off with a qualitative study using one-on-one interviews to explore a bit the public perspective about the prevention of cognitive decline in aging populations with people who have risk factors. And in this study, we found that it was for people very difficult to conceptualize that the risk for cognitive decline. To illustrate this a bit, people had the feeling that dementia would occur decades into the future, and had quite some difficulties with estimating how certain smaller lifestyle changes would lower that future risk for cognitive decline. I think this also nicely illustrates the potential of such a risk prediction model that Stan showed in the previous slide, where people get insight into what a certain behavior change can contribute to lowering the future risk. We also found in this study that for people, it was very difficult to change specific behaviors. Overall, they had quite general intentions towards living healthy, but we observed that it was very difficult to change risky behaviors such as smoking, overconsumption of alcohol, or unhealthy dietary patterns. And that was partly because most of these participants in this small study used all or nothing thinking towards making changes. They perceived that quite radical change of lifestyle was needed in order to succeed. And hardly anyone had a specific goal or a specific plan to start with a healthier lifestyle. We also used these findings from this qualitative interview study to construct a questionnaire and validate the findings on a population level and to identify relevant determinants of behavior. The analysis is still ongoing, but I can share a couple of preliminary findings because I think the findings nicely illustrate that simply having awareness of a risk perception is not enough. We found that the relationship to actual health behavior and the willingness to change that health behavior was also really strongly influenced by social factors, such as social norms that people perceive or the perceptions they had about other person's behavior. And the willingness to change was also strongly correlated with the experienced self-confidence and self-control that people experienced. These findings are, of course, still preliminary, but will follow due to this year. And these findings also provide some input for some of the functionalities that we incorporate in the Lethe app, for example. So what I will do in the next slide is I will guide you through some of the functions that use behavior change technology. So in Lethe, we have the task list and the calendar. Stan already showed it briefly, but that helps people to gain a good overview of the things they have to do. And it helps them to plan certain activities. I think the tiny habit feature here is also quite novel in this approach because it provides for all the 8 lifestyle domains small goals and small plans that the participants can use to get inspiration about changing those small things in their daily routine, because that can be quite challenging. Another functionality that the app provides is self-monitoring. Participants are able to track the number of steps they set per day and a lot of other functions as well. The number of cigarettes, they can track it if they want to, the number of alcohol consumed. But the app also provides, based on passive data that we gather, a weekly score and with an accompanying feedback message to stimulate gradual improvement over time. And so these are a couple of functionalities that we embedded in the Lethe app that guide participants via small sub-steps towards a larger goal of having a healthier lifestyle. Something which is very explorative, and we haven't implemented it yet, but hopefully we'll do in the future, is notifications that we send to the participants. And these are a bit based on adherence paths that we developed. And based on automatic and passive data, we verify the adherence of each participant. And to give you a short illustration, for each of the 8 lifestyle domains, participants are labeled in the green, yellow, or red path. And this is shown also on the professional dashboard of the clinicians and offers the clinicians insight into how people perform on certain lifestyle behaviors and where they might need additional in-person support. So in that terms, it can be a valuable tool that the clinicians can use while supporting people. On the other side, the aim is to also use these paths to send feedback notifications via the push notification functions on the smartphone to provide with a bit of personal guidance. And to give you an example of these feedback messages and the behavior change methods they embed. An example is a colorful meal is often healthy. How many colors were on your plate tonight? And that's the behavior change method elaboration, because it asks people to reflect on what they had for dinner. Another example is you did 4,500 steps yesterday. How many did you do today? So this message provides feedback on the behavior that people did yesterday, but also tries to stimulate using the app to self-monitor the things that you do today. And a third example is embedding a new routine is quite challenging. When do you plan to do your cognitive training? This, in the first part, acknowledges that changing your daily routine is quite difficult. And on the other hand, also offers people an opportunity to embed an action plan in their daily routine to change it. These were a couple of the examples that we tried to embed in Lethe. There were more, and I'm confident that we also develop more of these things during the trial. A take-home message for my presentation is that health promotion is also about changing specific health behaviors, more specifically about changing these little determinants that influence behavior. And it's no silver bullet, changing these determinants, but they will increase the likelihood of effectiveness in terms of adherence. And that was, I think, the last sentence of my presentation. Thank you, and I'm happy to answer all of your questions in the discussion part.
Thank you very much to both Stan and Hiron. Yes, we are slightly late in the agenda, but we will still have quite some time for questions. So I will now introduce my colleagues. Actually, we will present the Alameda studies from a different, again, perspective. So we heard already from the more specialized AI predictive modeling from Stan and the behavior change intervention. Now we will hear from 2 of our clinician representatives in the consortium. So first, I would like to introduce Professor Leonidas Stefanis, neurologist at the National in Kapodistrian University of Athens. Please, Leonidas.
Hello, good afternoon, everyone. Can you hear me?
Yes, we can.
You can hear me, okay. Very glad to be part of this webinar. My area of expertise is I'm a neurologist working mostly in the field of movement disorders and Parkinson's disease. I've been involved with my group here in the National Kapodistria University of Athens, using digital biomarkers to unveil disease progression in Parkinson's disease as part of the Alameda project. Hope. Okay. We've been implementing the Parkinson's disease pilot. Just a few introductory words about Parkinson's disease. Parkinson's disease is well known for affecting motor functions, but it's of course much more than that. It also affects many non-motor functions as well, including sleep, autonomic function, neuropsychiatric features develop, and of course there is affectation in the cognitive domain of patients as the disease evolves. There are scales that are available to clinicians to capture these dimensions, but of course these symptoms, as you will see, especially in advanced disease, fluctuate, and the way we do it in the clinic, in the daily clinical practice, we do not capture this fluctuation. And of course, we do not do it in a continuous way in the home environment. As you can see in the graph on the right, although the disease has a pattern of development, it's a neurodegenerative disease, but the trajectory each patient follows in terms of how non-motor and motor symptoms evolve may be quite different depending on the particular subject. It's something the patients often ask us themselves. How is my disease going to be in sometime down the line? So it's very important to develop tools to predict how the disease will evolve over time, including both motor and non-motor aspects. The classic motor symptoms of Parkinson's disease, you can see on the top left here, the tremor, the rigidity, the bradykinesia, postural instability, which is a late feature. These may, of course, affect the ability to perform tasks of daily living, such as preparing a meal, eating, dressing, bathing, and in advanced stages may affect also speech and swallowing. But as I mentioned, there's a whole host of non-motor symptoms from the neuropsychiatric domain, sleep domain, autonomic, sensory disorders, mood disturbances, and cognitive impairment. And the stage of the disease we're most interested in is the most difficult to deal with, is advanced Parkinson's disease. Usually at this period, we have the so-called motor complications in which there's a fluctuating response to the medication with wearing off periods and periods with excessive movement that are called dyskinesias. And you also have these axial symptoms such as falls, freezing, difficulty walking and turning, dysphagia and dysarthria. And of course, you have intensification of all the non-motor issues that I mentioned before, but especially autonomic dysfunction, neuropsychiatric symptoms, and the cognitive decline. So this is a period that's very volatile. It's difficult to manage because you try to fix one thing and something else goes wrong. And of course, it's very difficult to predict each patient's trajectory in this volatile period. So the vision we had in Alameda was whether we could use continuous and more intensive, but as minimally intrusive as possible, and monitoring through sensors. So both continuous and intermittent monitoring and interactive devices, not only sensors, to predict in individual patients what could be the pattern of progression of Parkinson's in the period of a few months to a year. So we decided that the best group of patients to follow would be patients with advanced PD, whereas we have the need there to follow closely these fluctuations. These are not only motor, but also non-motor fluctuations. And so as to be able, having this information in the future to predict worsening and perhaps intervene early in order to address these issues. I have to say this is as opposed to Lethe, this is a non-interventional study. So this is mostly about predicting disease progression rather than intervening at this point. We would see this more as a later evolution of this project. So we're using sensors to monitor both motor and non-motor aspects of advanced Parkinson's. The sensors are applied to original design to a cohort of 15 subjects with advanced Parkinson's, and we hope to have them at least for a 6-month period engage in the project. We have a regular use of in-clinic established questionnaires so as to have device-independent data and to correlate that to the data generated by the sensors. And we've also implemented, because as I mentioned, sleep and autonomic function are really important aspects of these advanced Parkinson's disease patients. We also wanted to gain objective measures of those parameters. So we have objective sleep lab and autonomic lab data for these subjects. So what do we do at the beginning and the end of the study? We hope to have autonomic and sleep lab studies. We have devised a specific socio-demographic financial status questionnaire in order to correlate that to all the parameters that are going to be collected in the study. As I mentioned, as a kind of a ground truth baseline, we have these in-person clinical assessments with hospital visit in order to correlate those with the digital and questionnaire data through the appliances. So every 3 months we have scales and questionnaires for both motor and non-motor functions, quality of life, etc. All these aspects that I mentioned before. And this is the promotional material we've used to enroll subjects in the study. We stressed here, this is in Greek, of course, you will not understand it, but just to give you an idea. But our main goal was for them to use these devices, but to be as unobtrusive as possible. So for the daily monitoring, we use a smartwatch to monitor heart rate, blood pressure, gross aspects of mobility, and ambient conditions. We use a smartphone with a WellMojo application to monitor some basic mood, diet, exercise data, and just to make sure they take the medication as prescribed. And we also have a feature, an interactive feature for them to just jot down very, very briefly the pattern of daily motor complications, because as I mentioned, this is an essential feature of the advanced phase of the disease where they are. But this is not a fully developed questionnaire, it's just a very simple thing for a daily recording of what they perceive as their day as in terms of motor complications. And then we have a facial recognition during the interaction with the devices, but we have not implemented this yet. So you can see that during the whole period of the study, we have all these parameters being measured. So this is the daily monitoring. And then and on a weekly basis, we have some more structured questionnaires that are presented to them through the phone, where they have to through the smartphone, where they have to respond to some more classic questionnaires. But we have also devised some more specific questionnaires for their activities, for the socialization pattern, which is very important and for their mood during the period of this week. And on a monthly basis, we ask them to complete a questionnaire for quality of life. This is the PDQ-8. And then we have, as I said, this is kind of the continuous monitoring, kind of this intermittent intensive monitoring. Once every 3 months, we ask them to also wear a smart bracelet in the other arm, and they are prompted during that week to have a intense half-hour walking, and during that period, they're of course monitored by both the smartwatch and the bracelet. They use a smart mattress during the evening to monitor sleep. And also during the clinic visit that occurs just after this period, we also have them do certain tasks wearing a smart belt and smart insoles. And we record, of course, the motor features during these tasks so as to, again, correlate the ground truth with the recording from the various gadgets. Every 6 months, we also do some cognitive tests, the virtual supermarket test and the line tracking test. These are tests that are geared to measure mostly the executive visuospatial function and working memory, because these are the abilities that are mostly affected in Parkinson's. The current status is that we do have our subjects enrolled. We did have some dropouts along the way, that subjects would not realize the somewhat demanding nature of the procedure, but we, however, have substituted them with the new recruits. And overall, we're following the protocol as planned, with some changes. Like, for example, we decided finally the insoles and the smart belt, we would only use them in the clinic visits. We're, of course, collecting the clinical data at the same time as we're doing these sensor recordings in the period of intensive monitoring. And we expect all these data to finally put them together and correlate them with the final outcome, which will be the comprehensive clinic visit at the end of the study, using machine learning approaches in collaboration, of course, with all the other partners in Alameda. Just to see an example of the right of the expert dashboard, which is available to the clinicians. And we have defined some critical thresholds of deviation of recordings, but as I said, this is not that much intervention study at this point, and we hope to have at that point in perhaps a later version of this project. So it's mostly to correlate all the digital data with a final outcome, which will be the progression of the disease at the end of the study. Thank you.
Thank you, Leonidas, for this very clear explanation of what we are doing around Parkinson's. I will now leave the floor to our colleague, Ludovico Pedula, who is instead representing the pilot sites in multiple sclerosis. Ludovico is a researcher working in the Italian Multiple Sclerosis Society Foundation, and this organization is indeed leading the multiple sclerosis pilot site in Alameda in Italy. Ludovico, the floor is yours.
Okay, thank you. Can you hear me and see my presentation?
Yes, yes, now in presentation mode. Perfect, thanks.
Okay, I am Ludovico Pedula, and I am a researcher for the Italian Multiple Sclerosis Foundation. My background is as a physical therapist, so I will present our pilot study from a clinical point of view, with some hints about the main research question within Alameda. Multiple sclerosis is an autoimmune inflammatory disorder of the central nervous system which affects mostly young women and is the second most common cause of disability in young adults after traumatic brain injury. It can lead to a wide range of symptoms, including motor, cognitive, mood deficits, and also leading to reduced quality of life and social participation. It is unpredictable in the relapsing remitting course, which you can see on the left graph. It is the most common course of multiple sclerosis where sudden relapse can occur, followed by complete or partial recovery. We can have also other courses such as secondary progressive or primary progressive multiple sclerosis, but in Alameda we focus on the relapsing remitting MS course because it is the most common, and today there is no possibility to predict the risk of a relapse. So the most common patients can be exemplified with Bianca, who is a 32 years old woman with a history of disease of 5 years and a mild disability. In her life, we may suppose that she has to take a very important decision in the both in the private and the social life, and the possibility to know the risk of occurring a relapse may help her in taking the correct decision at the correct time. So the Alameda technological system aims to collect data from different devices and sensors, and to develop an algorithm able to predict relapse risk based on this patient-generated information. I will briefly go through the data collection because it is similar to the one exposed by our colleagues in the Parkinson's disease pilot. Something which is important to note in the MS case is that usually we collect data from specific time points, for example, at the baseline, with different motor and cognitive tests, but also with questionnaires investigating the perspective of people with MS about their symptoms. And then after about 6 months, in the meantime, a relapse may have occurred, and we can have the chance to see the sequelae only after some months of time. With the new Alameda data collection journey, we aim to have a continuous data collection, continuous monitoring, both passive with smartwatch and other sensors, but also active with the input of the patients who can answer to relevant questions through their smartphones. The relevant questions include both validated questionnaires, but also some red flags that we identified together with the final users, namely patients and caregivers. This is something that we think may be very important, maybe crucial for our data collection, because we will investigate domains that really matter to people with MS and that are informative about signs and symptoms that are predictive of relapse as expressed by the experience of people with this kind of disease. In particular, we developed a participatory governance using the model offered by the project Multi-Act, which the foundation coordinated in the last 3 years. And we had at the consortium level an engagement coordination team in charge of representing each relevant stakeholder and to guarantee the representativeness. In every country, we had some local community groups because the needs of people with different disease are different, but also because there are differences in the social context of the 3 countries. And at the level of the Italian pilot study, we had a group of people with MS. The selection of the representatives was also driven by a person with MS who identified the important characteristics that all these participants should have. In particular, they were on a specific phase of the disease of interest for these studies, namely the relapsing remitting form, but were also connected to a network in order to take their point of view, but mostly the perspective of their community. The main goal of the local community group was indeed to ensure representativeness and bring the voice of the community. What we did with the with the local community groups, we ranked the domains to monitor in order to identify the most important, which were mobility, cognition, and emotional status in this order. And for each domain, we identified the red flags that people with MS considered as important to monitor during daily life in order to identify predictors of relapses. Moreover, within specific focus groups, we developed together with people with MS and clinicians the questions to be asked to participants in Alameda with the a lexical expression that was understandable from every participant. Up to date, we almost completed the enrollment of participants, which will be 20, and started the data collection with the challenges to balance between the gathering informative data sets and minimize participants' burden. The goal, of course, is to maximize adherence. And I must say that the engagement, the early engagement of the final user into the decision of the project seems to be very promising to increase adherence also in these long and quite important projects which need a very high participation from the user. The main aim of the first analysis is to identify usable devices which are promising to collect relevant data to predict relapse risk. And as future steps, we aim to co-design with all the relevant stakeholders, including people with MS, the definitive clinical trials to validate the Alameda toolkit in relapse risk prediction. As well, we may think to extend this toolkit to other research or clinical questions, such as to identify the conversion from the relapsing remitting to the secondary progressive MS course, or predict the worsening of the disease in the primary progressive course. So this is all from my side, and thank you again for the possibility to explain our pilot study.
Thank you very much, Ludovico. I will invite our panelists to switch on your camera if you wish, and maybe we can take some questions from the audience, even comments from yourself, and of course from Kyriakos would be very much welcome. I would maybe break the ice, making an observation. We have discussed earlier how critical is to find this balance, let's say, between the excessively long study, might be excessively burdensome study length, but also the necessity for a certain timing for meaningful data generation. So this was the case, for instance, as mentioned in Lethe, to capture some meaningful changes in Alzheimer, and we experienced also some strategies to find this balance in Alameda. If you would like to comment on that.
Yeah, maybe I can start with. Indeed, we discussed it very long in the proposal phase already. How long a pilot needs to be to possibly see a progression, a decline, or a decrease in memory functions based on an intervention, so to say. And I think we were even longer at the beginning but of course the European projects have also their time limit, let's say. But we agreed then to do a 2-year study, and indeed this is one of the main challenge for us at the moment. And you have seen the talk of Jeroen. We tried a lot also in the consortium already to find mechanisms to keep them, to keep the participants really adherent to use the app and the Fitbit in our case, and fill the questionnaires for a very long time. We also tried to make the intervention setup very simple. We just have one variable and the app, so to say. We had at the proposal also some IoT devices and other devices, smart home devices in planning, but we agreed to make this very simple to possibly keep the patients or the people adherent to the project a long time. Of course, and this would be maybe a question for the colleagues from Almeida. Did you had any mechanisms to stratify in the selections of the participants to select, so to say, participants where you expect a decrease or a change of the status in your 2 diseases in these 6 months, so to say, to be able to detect with digital devices some changes in the behavior?
From our side, in the realm of Parkinson's, I mean, that's one of the reasons we selected patients with advanced disease, where, I mean, as defined with the emergence of these fluctuations mainly. So this would enhance our chance of seeing a progression over a 6-month period. But again, you're right. I mean, maybe we will not see that much of a progression. And that is why actually now we're already, I mean, some patients are already, beyond 6 months and are going strong. So we hope to have, more than 6 months for most of our patients. So up to a year, perhaps, for most of our patients. So I think within a year we'll probably, see something. But again, it's a trade-off, of course. And but we've seen that the patients who have endured the first couple of months of the study, that then they don't mind continuing. And we've seen also that they're also adherent to this intermittent, more intense monitoring. which we thought may be challenging. As Ludovico mentioned, we also had this. We planned this in collaboration with patient groups and their caregivers, so to have a more realistic sense of what they could do. But again, as I mentioned, we did have dropouts despite this. Had a few dropouts. So it's not easy, but and it's obviously a very select group of subjects that we already have a strong relationship with them for the most part that have decided to engage in the study.
This keeps,
But,
this helps, yeah.
Yeah.
Very interesting.
Yeah. And like I said, we did change the part of the intensive monitoring period. We decided it was too difficult for them to have all these devices at home. So we just provided them with a bracelet as an additional thing. And then we did the evaluations with the other appliances just at the visit in the hospital. So we tempered it a little bit, but it seems to be working in this fashion.
Concerning multiple sclerosis, it is very hard to have included people at risk of relapse, because this is the question that actually we would like to answer. So we, of course, elaborated some inclusion criteria in order to have people during their active phase of the disease, which is in the first years after diagnosis. So we have people under 45 years old, which is also good for the compliance with the technological devices. And something that we are thinking is about following the occurrence of relapse also after the end of the monitoring, so that we can maybe have some predictive signs during the monitoring, but if we see the relapse, we can record also if they concluded the monitoring time. So this may help us to see some fluctuation.
Yeah, thank you. Interesting.
I was very interested to see the interventions you have in Lethe, and we do have just a very little bit. I mean, we've changed it wasn't initially in the design, but we've changed a little bit the WellMojo application so that they do get some they do get some feedback as to how they did compared to the previous week or month, how they have been responding. And we're just implementing that now, so we'll see how that, hopefully will improve also the compliance, like you mentioned. And so we're still waiting to see how that will go, but it would be very nice for us also to move into that direction more.
Thank you to all for this clarifying discussion. Kyriakos, would you like to add some words?
I would like to ask the PIs, the principal investigators, Professor Stefanis and Hanke, as the next steps that you would now envisage in essence. I mean, first and foremost, scaling up the studies. I happen to know, for example, that this may not be as simple or straightforward in the Greek context, in essence, for Professor Stefanis. But how about scaling the studies in the Netherlands and Austria, and indeed in Greece, yeah? And beyond that, and based on the evidence that you will be gathering, are there any thoughts towards developing a product and having it regulatorily approved for use in the healthcare systems?
Yeah, at least for Lethe, of course, this is somehow the aim. And also, I mean, in the last year, there are there are or is one or more competitor also on the market who try to have a similar approach on dementia lifestyle intervention and certify the device as a medical device, or at least a device which can be part of the medical product, the catalog, let's say. Of course, this is the main aim. I mean, we have at the moment an hybrid intervention approach because we want to get sure that we keep adherence very long to get the data and then hopefully demonstrate some evidence. But of course, as a long-term goal, it is of course the vision that if persons and we see the progression in bioinformatics and other fields know of their personal risk towards dementia, for example, or any other chronic disease, that they can join with Lethe set up, so to say, a remote intervention program, so to say, to target their individual risks profile or their different lifestyle categories. And this is also the point what Professor Stefanidis said nicely. I mean, at the end, it is of course the aim to pick the person where it stands, for example, because everyone has a different lifestyle. Maybe the one likes to eat more healthy, the other wants to make more sports. So I think the intervention protocol at some point needs to be individual to also achieve a higher adherence rate, or also what Jeroen talked about, a higher rate of that you change your lifestyle, because what is very far away to change, you maybe will never reach. But of course, we work at the moment in exploitation models, and this would be one of the big goals if we could hopefully show some evidence to open this solution up for any person at risk at any age. Yeah.
Yeah, as regards to Parkinson's, I also see it more perhaps something further down the line, perhaps in terms of applicability. This is what we're trying to develop is more of a prediction tool. So without, as I mentioned, that much the intervention aspect, and but of course, if the data are convincing that some parameters are indeed, predictive, that could have some, market value. And we have, discussed this with colleagues in the consortium, in the exploitation realm.
I might just add that actually there is an ambition, let's say, in clear ambition in terms of what's happening beyond the end of the project in Alameda with the development of what we called the Alameda Innovation Hub, which will basically be the gateway offering access to data sets, algorithms and tools, and also the possibility to integrate other solutions. So there's, let's say, the willingness to scale in different directions. Of course, the scale at country level, the scale in terms of integration of other solutions, other product owners that are working on testing and prototyping hubs or devices that could be easily integrated in the system, in the AI toolkit. And I would say also disease level, because most of the features and the variables that we are recording are indeed relevant for other chronic diseases. So there's also another layer of scalability potential there.
Thanks, Valentina. I'm not sure if we haven't have any questions from the audience. I do have another one, if I may. And
yes, we still have a few minutes. Yes, if our panelists can.
So, our academic colleagues mentioned adherence, and adherence is a very key concept. We start with adherence to medicines, which has its own published literature, and well knownly so. But here, I think in both of these solutions, we have two types of adherence. First and foremost, adherence to using an app. And secondly, adherence to what the app is suggesting one does. And I wonder what your thoughts and experiences have been in that regard, in essence. How do we maintain adherence in those two respects? Thank you.
Yeah, if I may start shortly, definitely, I can completely agree. And I think, at least I don't have personal experience, and I think there's also not too much in literature on such a long life terms. Of course, 3-month study, some weeks, and so we have a lot of experience with digital devices, which are, of course, quietly good accepted, I would say, also app usage. But I know it from myself, for example, if I start to track my food after some months, I stop doing it because it's too cumbersome. So I think there's an experience missing, which is also very interesting for us to see how it goes. I mean, we have some side ideas. For example, here at the university, we have a group or some people developing some gamification elements that you can collect some issues or some things and these kind of known methods, which we possibly are able to fade in on a later stage after a year. But in general, yeah, I think the first thing, like I mentioned, is that we plan at least at the beginning and for a long time also the physical contact, so to say, to keep them adherence and also notice in an early stage if there is yeah, some problems with the motivation or something like this. But yeah, it's still a big adventure. And yeah, the other thing what Jeroen mentioned also, we have this thing with these different paths, so that we also digitally see in an early point if a person doesn't fill his questionnaires, for example, or doesn't use the wearable. And then, of course, we need to check with the person if he's still willingly to contribute to the study and so on. These mechanisms we have in place, but yeah, Almeida has already experience with dropouts. We started in end of January. We have so far no dropouts, but we also just in the beginning. So let's see how this goes. Yeah.
And shortly comment on that, Stan, is we also try to build a bit of a community. We have an app group for participants that they can join and share also their experiences in the trial. And we try to build in that social component, also in the contact between the clinician and the participant of the study, between the participants, to at least increase the adherence in the study itself.
Yeah, that's exactly what we also have done. We created a community. We tried to create a community, both physical. We met once, and then we opened the channel on the social networks to exchange experience, issues, and this helped so far. So we will see if it keeps going until the end of the study.
In terms of adherence with the devices, I think, the smartwatch is something they all tolerate so far. It hasn't been an issue. And also the intermittent use of the bracelet is also, and even the smart mattress we have, there have been no problems with that. But it's true that after some time, some of them may not be filling out the questionnaires, at the rate they should, and then we have some monitoring that, like was mentioned before, and we try to intervene in a way on a weekly basis for those who seem to be lagging behind in their filling out the questionnaire. So it's not something that you just leave an automatic pilot and happens. You have to be on top of it. And that's, of course, the part of the study. If you want to market this, you wouldn't be able to do that. So that's it's not the real life, like it would happen. But it's part of the study in order to collect the most data you can. But it may be somewhat artificial in that sense.
The question, Kyriakos, for the colleagues answering, I think we are already over time, so I would really like to thank you all. Hope that our attendees enjoyed. I think we enjoyed a lot to know more about each other, the two projects. So let me just closing the sessions, reminding the main communication channels you can use to reach out both Lethe and Alameda, and of course follow the developments of the pilots and the studies, and eventually also get in touch for any opportunities for further research collaboration. So thank you so much, everyone, and have a nice afternoon and weekend.
Sorry, Valentina, may I take one more minute? I would like also to, yes, I would like also to thank Dr. Laura Contor, our newly appointed PO from Hadea, that she was attending our webinar today. She had the time, and I would like to welcome here in the Alameda project. Also, maybe I can unmute here, sorry.
If she's still with us, yeah.
Yeah. Dr. Contor, can you speak? It's okay, maybe we have an issue. Okay. We'll talk with you later. I don't know why.
Thank you very much, Panos, and nice to meet.
Can you hear me now?
Yes,
Yes,
we
we
can hear
can.
you.
Okay, sorry, it was a bit complicated technically. Well, thank you very much for those nice words and for the very nice letter you've written to me. That was and well, to my predecessor also. And I'm looking forward, obviously, to work with you. And the presentation seemed to be very promising and very clear, and progress is going along slowly and surely. So yeah, let's see how the future will develop and how we'll be able to work together.
Great.
Congratulations
So
for the meeting today. It was very nice.
Thank you very much, and thank you for taking the time to join.
You're welcome. Thank you.
Thank you.
Bye.
Bye, bye.
Bye bye, everyone. Thank you so
Bye,
much.
everyone.
Bye, everyone.
Talk to you
Thank
soon.
you.
Bye bye. Thank you.